Hello, thanks so much for having me today. So we're going to talk today. When I transitioned, I started laparoscopically and then transitioned my entire practice over to robotic surgery in 2020. And so my last thing that I transitioned from was robotic flexure, it was robotic flexure mobilization. So I was lap flexuring, and I'll kind of talk specifically about my learning curve, things that I ran into when I transitioned, and then kind of tips and tricks to try and avoid that, especially with different types of patients. I'm an intuitive speaker and proctor, so I'm teaching splenic flexure mobilizations, and I'm an almost always splenic flexure mobilizer. So when I trained, we were always mobilizing flexure, and so now I almost always do it. It's beneficial for me because I never am sad when I mobilize extra. I never am sad that I have extra length. There's been times previously where you think you have enough, and then you have to go back and mobilize later. So I would tell you I almost always mobilize. So why take the corner robotically over laparoscopic? What are the benefits? For me, the surgeon autonomy is most important. I have 3 arms. There's a stable field. Things aren't moving around. I have control of the camera. And the wristed instrumentation really helps with dissection and also helps visualization and the stability to be able to move through the different planes. Also, when you're doing part of the operation robotically and part of the operation laparoscopically, you're going back and forth, and so you do lose some efficiency with that. And so when I transitioned to all one modality, my laparoscopic times and my robotic times after I transitioned I'm actually faster robotically now because you're going to be faster and more efficient at whatever you're doing the most. Also, the team is aware of the surgical plan, so I'm not going back and forth between lap and robotic during the entire case. I'm just doing the entire thing robotically. So why is the flexure difficult, especially when you're talking about robotic surgery? So when you talk about port placement, Dr. Cannon showed us earlier today one of the different kinds of port placements where you're going from the right lower quadrant up to the left upper quadrant, and sometimes that most of the time works. But sometimes when you have a flexure that's really high, or you need to be able to you have a proximal descending diverticulitis, and you need to be able to get into that area, and you need to go to the transverse colon. You can put your ports a little bit, so the port placement can go from here to here, or it can go from here to here. I'll come just a little bit to the left of the falciform, and that helps you be able to mobilize up here without any issues. Also, you want to make sure you're not going to have issues with instrument reach or collisions, and some people don't have table motion, so some people are having to double dock if they're doing the flexure robotically, which then is negative for efficiency, which is one of the things we're trying to avoid. There's also anatomic variation, so patients, like we talked about, are morbidly obese, BMIs of 50 to 60, and also sometimes they're stuck to the spleen. How do you work through those? Obviously, you want to always look at your preoperative CT, which will help you know some of the challenges that you're going to run into in preoperative planning. So for patients who are morbidly obese, bariatric ports are going to be helpful. Also, laparoscopically, when I set up, so we've talked about I use the same thing that we talked about previously, but for the flexure, if I'm concerned and I'll laparoscopically run the entire paracolic gutter. So I'll make sure that I can feel the sacral promontory, I can run up the side of the paracolic gutter, and I can also roll the omentum back and see how much the colon comes toward me. That's going to tell me if I need to go to the flexure or if the flexure can come towards me, and that's going to also tell me if I need to set up doing the flexure first. I do usually like to do the flexure first if I know that I'm going to do it, because if, God forbid, I have to convert, then I'm having the flexure's done, and then I don't have to go back and do it later. Worst case scenario, I can do most of what I need to do through a small fan and steel incision, or if I needed to do hand assist or anything like that, a fan and steel incision is better off than a midline. So I would recommend doing flexure first, getting set up for that, and then proceeding on. So some of the things that you can talk about, the anterior approach is obviously through the gastrocolic ligament, lateral, medial, like we've seen before, and then also inferior, if you continue that up, taking the IMA. If you do the steeper port placement, that will help you if you have a higher flexure, making sure that you can move your arm toward the right lower quadrant. So this arm, as the robot's docked, you really want to make sure that this arm is pulling down. So a lot of times, intuitively, we try and go up. We'll try and lift up like we do laparoscopically to create that tension, but you really need to come down to the right lower quadrant or to the pelvis. And if you do that, the arm will come this way out of the way, and then you're able to come up and over, and then you can create tension with your left arm, and I'll show you that in some of the videos in a second. But that does help you get around that corner. Table motion, if you have it, is great. Tackle it from all angles, so circle like a wolf. I love that. I'm taking it. And medial to lateral is always an option. It's one of my favorites. 5s are free, so if you ever need to put in more ports to be able to get, so in the patients who are morbidly obese, put in more ports if you have an assistant that can help you. Don't feel bad about it. And then some other things you can do is using your, you can flex the XIs toward the F, which will give you some more space, especially if you're having to do that proximal descending diverticulation. You need to clear that transverse colon. And then also going 30-degree up on the endoscope will create some collision. So those are all good options. So talking through splenic flexure mobilization, this is one of the ones that I did all the things. And so you have to be ready to do all the things. So anteriorly, this is a floppy flexure, but it was for rectal cancer, so she needed length. And so starting anteriorly, really exposure is key all the time. You want to make sure that you have good tension and that you're able to continue the planes and make sure you know where you're headed. So anteriorly, you would just continue this plane around like we've seen previously if you're taking this approach. You're wanting to pull down with your arm. You can see that down here I'm pulling down with my arm, or laterally. So you want to stay in front when you're using your 2 arms to prevent collisions. You want to keep your small grasping attractor ahead of your bipolar or underneath it. That will prevent your collisions. But you can see there's not a great lateral plane here. Like usually this will pull apart, but some patients are sticky. They don't all come, with easy flexures. So we just have to be able to be flexible and move with whatever they give us. Medial is one of my favorite approaches as long as you can find this, as long as you, the IMV is really easy to find. Usually you can definitely find the ligament, and if you go look past the ligament, you'll find the IMV, go gonadal underneath, and then you're able to kind of gently, obviously with, tension is important because you don't want to avulse, but going underneath and really dig, kind of separating out that plane. And then you can take, the question is, when do you take the IMV? I take the IMV when I'm worried that the amount of tension I need to put on to continue my dissection is going to avulse it. So I'll take it pretty early. As soon as I can see that plane, you can see pancreas behind there. And then I'll take the IMV with whatever way you want to, vessel sealer, clip, whatever works. Pancreas is, again, down below, but you really can't get a better splenic flexure mobilization by taking it off the base of the pancreas. So if you've mobilized all of these ways and you have medially and off the base of the pancreas, if you still don't have length, you need to start taking vessels. So this is a really good way to know kind of if you've won. Here we see stomach coming up, and so a lot of times I'll start, if I'm struggling, I'll start medially because it's an easier dissection, and it helps you with the lateral dissection as well if you can't get retraction. A lot of the times when people have trouble, they can't pull this down. And so starting here then gives you your planes and you can continue kind of working known to unknown. And then we'll go back and complete the dissection anteriorly. Sometimes you're going to be able to use your third or your assist arm to pull up. Sometimes you're not going to be able to. So you just have to figure out how your support setup is and how your body habit is. And if you can't go up, then you go down and under. And those are the 2 options. Once that clicked for me, it made a complete world of difference in splenic flexure mobilization. Here I'm connecting my 2 planes from below. So this entire splenic flexure is will now be mobilized, and I'll be able to go back down and finish the actual operation that I showed up for. But here we are. Yeah, so when you flex to the F, and if you look at the top of the boom, there's the FLEX. You can actually move all the arms toward the F. That will go toward flexure. And if you need to move all the arms toward the X, that's the pelvis if you're docked for a left. And so it really gives you extra space to get to that transverse colon. So you can get deep into the middle of the transverse colon by doing the flexure, by flexing toward the F. So flex towards F for flexure, X towards pelvis, and that will give you extra space if you need it. Create some space with your arms to be able to do that. If you want to pull the colon up and out, this is the biggest thing that helps. Get underneath, make that V, and then you want to make sure that you're pulling up and out versus digging in. You need to make sure you have retraction. If you don't have retraction, you're digging in a hole, and that's when you get into trouble in that retroperitoneum and into bleeding. Even if you're not mobilizing the entire flexure, you need to take this off the kidney. Medially, as far as you can go, make sure this is all off the kidney because you're going to have so much more length if you can take it all the way up there. And then if you need to take the rest of it for flexure, you have length if you need to. Inferiorly, we stent all of our patients. We actually, not stent, we inject ICG, and we do our own cystos, which doesn't add a whole bunch of time, but it helps a lot for identification. You can continue that plane up if you need to. So tips and tricks that I've learned over time, really making sure that you're staying ahead and moving in tandem with your arms, and then following that white line. It is so easy to get out of the white line, so really making sure you're in plane. If you're bleeding, you're too deep. So you really want to make sure you're changing, you're going back to plane always. I operate a lot of times in, I'll show you in a second, in angio mode, because you can see the white line really well. Again, you're seeing that I'm walking up here, so we're keeping that assist arm either in front of or underneath, and then bringing the colon up and out of the body. You always have to take the piece of momentum that's stuck to the descending colon off, and then you want to pull down with your arm here. You're going to come up and over into flexure, so you create your own space with that bipolar. You're creating your own space and being able to get through flexure, and then you just continue pulling your arm down away so that you're not creating tension in our collisions. Again, going back to the ureter is always a great place to start. We stent all the time, so I can always see it. You can see that white line, and if you operate in Firefly often, you're easily able to make sure that you continue that dissection and that you're safe. You just carry that all the way up, and you're good to go. Sorry, I can't get out of here. So one of the other things is when the omentum has an omentum, so your BMI is 60. So again, use, like we talked about, just know that it's gonna be a hard case. It's gonna take time. And so really you just wanna stick to the colon. If you know where the colon is, if you can find the colon somewhere, you can keep out of trouble. The medial and lateral planes are gonna be the easiest, and likely because the omentum is so bulky, that anterior plane and the omentum is gonna be the hardest. So anything you can do to free everything up and then pull the colon out toward you is gonna make it easier for you to be able to see. So those are some of the things that I've learned. All right. Thanks so much.